We will ask Dr. Mahmoud to tell us about the management of chronic venous ulcer.
Good morning, everyone. Management of chronic venous ulcer. Pathophysiology of venous ulcer is increased ambulatory venous pressure, which is increased more with deep venous obstruction than deep venous insufficiency, that more superficial venous insufficiency. And this is a seat classification everyone know. Wound debridement, American Venous Forum recommend thorough debridement of venous ulcer at their initial evaluation to remove obvious necrotic tissue, excess bacterial burden, and cellular burden on the dead cells. And it aims to remove slough, non-viable tissue, or eschar. Compression, improve venous hemodynamics, control edema, reduce inflammation, inflammatory mediators, improve microcirculation, improve arterial inflow, and improve lymphatic drainage. And American Venous Forum recommend compression therapy to increase venous ulcer healing rate and reduce risk of recurrence. And also in clinical review, in comparison over non-comparison, gave the same results. And this is the diagram in how to manage venous ulcer, either as reflux or obstruction. And we have to deal with the obstruction first before reflux. If we have the problem superficial venous system and perforator, definition of the pathological perforator means outflow more than 500 millisecond duration or diameter more than 3.5 millimeter. So American Venous Forum suggests ablation of both incompetent superficial axial vein and perforator followed by compression therapy. This is refluxing saphenofemoral junction, and you have to deal with it either with a different variety of treatment, endovenous laser ablation, radiofrequency, and so on. And this is the result of wound healing. This is incompetent perforator, and you have to deal with it by using injection. Here there is a video, but it doesn't work. The second level is post-phlebotic May-Turner syndrome, and national guidelines indicate to perform balloon angioplasty and stent. This is a case of May-Turner presented with pelvic congestion and healed venous ulcer after correction of the lesion. Post-phlebotic, according to classification of human JRA, endovascular management for class 1, 2, 3, 4A hybrid, 4B hybrid, or endovascular blast extension into the femoral or profound femorus, and the type 5 is contraindication. And stent rules, everyone is knowing about it. This is class 1. We have a 42 years old patient presented with both obstruction and reflux, and we have here a good inflow, but I don't know why the video doesn't work. And the first we did a reconstruction of this system and insertion of the stent, and later on stripping ligation after 3 months, and the wound get better and healed. The second case, we have patient 62 years old. The right side has femoral brachial occlusion due to old DVC, and left side iliofemoral occlusion due to old DVC. The right side, we have normal common femoral and iliac veins. We only did the perforator injection, and the wound get better and healed. The left side has lesion on the left iliac side, and we have good inflow, good femoral brachial access. We had correction of the iliac lesion by insertion of the stent, and also the wound get better and healed. The second case, we have active ulcer, and we have lesion at the common iliac, extended iliac, and which was corrected with the stent, and the patient had good inflow. In the class 4, we have hybrids like endovenectomy and or extension of the stent into the profound or femoral vein. Type 5 is contraindicated, but what will be the solution? Like in this case, we have type 5, we have 63 years old, post-phlebotic due to old femoral brachial and iliac DVT. And we have poor inflow, and we had tried surgical debridement and perforator injection, but it doesn't heal. Later on, we gain access from the popliteal vein and do dilatation of the femoral brachial axis, which make the wound to heal. And another case, 36 years old male with multiple leg ulcers. CT radiography show poor inflow and iliac lesion. We did only balloon dilatation without stenting, and also the wound get better. The other option for the contraindicated type 4 subalcer venous plexus injection, and the theory that the high venous pressure is conducted through this subalcer plexus and prevent wound healing. And we have a publication about this point. This case, a patient contraindicated to do angioplasty, and we did subalcer venous plexus injection, and it was healed. This one also in the right side, as you find, and the left side, complete wound healing. He had normal venous pathology. About vacuum dressing, we don't know if it is effective or not. However, American Venous Forum suggests against routine primary use. In conclusion, pathology of venous ulcer is one, increased ambulatory venous pressure. Etiology is different and variable. Surgical debridement and compression in the coronary stone. Assessment of the inflow on the venous reconstruction is mandatory. Thank you.
Thank you, Dr. Mahmoud. We have time for one question. Dr. Numantepe, please.
Thank you for this challenging case. I just one objection to your comments about type 5 patients, which I present our experience, because we believe that in very selected patient group with type 5, which is no inflow, with unhealed venous ulcer, we can do something with access PTS treatment protocol, and this patient is really suffering.
Yeah.
And contraindication is, I think, there's a huge comment, and we can do something. I will show you.
Yes, I think so. And if you have poor inflow and the etiology is elastic recoil and fibrosis, and you are afraid to gain access through popliteal vein and do dilatation and the insertion of the iliac stent, you can do all the balloon dilatation. It's like the theory of we have a tibial artery disease and you have minor lesion and wound, and you only do tibial angioplasty to correct the wound and into wound healing. And tibial angioplasty is short timings, only for less than 6 months. The same condition here, we can do only the balloon dilatation of the femoral bridge axis without insertion of the stents, and the wound start to be healed.
You cannot do just balloon dilatation with this, but you can make some fibrin remodeling with acoustic pulse effect.
I think so.
Well, thank you very much, Dr. Mahmoud. And I think this is exactly the topic of our next presentation.